All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. All right. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. In regards to the last journal club, if for any of those people who may be attending now who had attended also last month, we are going to be sending out a follow-up email. There was the report that was run that was pulled to create the statements of credit. You may find that you had attended and you should have your credit available and it says incomplete. That is going to be corrected later this week. And then when you are downloading, you should be able to download both of your statements of credit at that time. So we had a little bit of a website glitch for that, and we're going to get that corrected this week. And then one other follow-up thing, when you go to do your follow-up email regarding feedback, it's a potential piggyback talk after Dr. Narducci's discussion is coming up in February with Dr. Gonzalez, a psychiatrist, and he is requesting for the attendees to say whether they want one of 3 topics. One is management of ADHD at various levels of sports, including TUE. Now we're going to hear a lot about that from some respect today. Anxiety management in athletes, and then post-concussion psychiatric presentations and management. So kind of that post-concussion syndrome that leads to psychiatric presentations. So just if you wanted to provide in your feedback, if one of those 3 topics sound most interesting to you, that would be helpful. Okay, and then if you have any questions during the webinar, please submit the question and we'll review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and slides will become visible. The recording will be available for review from our website tomorrow. Dr. Dusty Marie Narducci has expertise in the fields of family and sports medicine. She is highly skilled in treating conditions such as neurodiversity, eating disorders, trauma stress disorders, complex concussions, and athletes with mental health conditions. As a certified eating disorder specialist, trauma therapist, intuitive medicine clinician, and yoga and meditation instructor, she provides top quality care and support. She serves as an unaffiliated neurotrauma consultant for the National Football League, team physician for professional combat sports, and founder of the Empathetic Athlete, a 501c3 dedicated to helping athletes with mental illness. And so we are going to have her take it away.
Awesome.
Here we are.
Thank you so much for having me. It's an absolute pleasure to be here, and I'm talking about one of my favorite topics in the whole world, to be honest. So yeah, this is my presentation, Unlocking Potential of How Sport and Exercise Medicine Clinicians Can Support the Neurodiverse Athlete. So we'll get into some stuff today about what neurodiversity is, how it pertains to athletics, and a bunch of other fun stuff. I can talk for hours on this topic, so trying to just condense what I think would be most important. So if anyone has any questions, wants more details about anything, please don't hesitate. Dr. Henny has all of my information. Okay, you can go ahead, Sue. I have no disclosures. And these are my learning objectives. I'm going to kind of skip over those now and just kind of move forward. And again, any other additional questions you have, just let me know. Okay, this is me. She's kind of already given me a little bit of a rundown. That's Mr. Pappy Van Winkle. He comes to the clinic with me. He's a great therapy dog and helps a lot with my neurodiverse athletes. So you can move forward. All right, so proposing a question. Have you ever observed an athlete who suddenly shouts? Maybe they're really distracted all of the time or just habitually late. I think we see this a lot. I think I've been all of those at some point, probably was today, but somebody who maybe is constantly like that, and you'll tell them time and again or offer them support, and it's just not maybe getting any better, and it's really affecting their athletic career, their social, friends, all of that, family, as well as academics. And what is our first reaction when we see that? I mean, just being completely transparent, I can get pretty frustrated. And, sometimes I feel bad for them, things like that. So stuff to think about when you see that. And do you think that they're trying to act that way? Or maybe they're underperforming on purpose for some reason. So I think we're all just learn so much when we look at our own bias, our own judgment, our own things like that. So we'll get into some of that today. You can go to the next one, Michelle. Well, to answer that question, did you ever consider the possibility that they might be neurodivergent? And I will tell you, I've seen so many athletes at this point that have been told that they weren't trying hard enough, they weren't good enough, been kicked off teams, lost scholarships, told that they were just anxious, or all these other different diagnoses, and it really ended up being neurodivergence and other things sometimes. But all right, let's get into it. Next one. So the basics, let's understand a little bit about what neurodiversity is as a definition. So I wrote a editorial in the BJSM. It was published this year in February. So a lot of the stuff that I pulled for this presentation was from there. It gives a little bit more detail if anybody wants to take a look at that. But if you see some of these little tables and stuff, that's where they're from. So what is neurodiversity? It's a natural variation in the human brain that influences how people process information, how they engage with others, with their surroundings, environment, all of that. So here's a list of some, not all, of what is considered under the umbrella of neurodiversity or the neurodiversity spectrum. Attention deficit hyperactivity disorder, some people call it ADD. There's a lot of debate, so we're not going to go there today, but autism spectrum disorder, which I'll get into a little bit more. Dyslexia falls under this umbrella, dyscalculia, dyspraxia, Tourette syndrome, obsessive compulsive disorder, which gets really confusing because a lot of them have a very similar presentations. So regardless, I care about our athletes, and I suggest everyone else does the same. Sometimes it's just the diagnosis can be helpful, but we can't get lost in that either. So next slide. So here's a little bit about what autism spectrum disorder is, also known as ASD. We used to call this Asperger's syndrome, that level 1, which I'm going to explain in a second. We don't use the term Asperger's anymore. Everything that is under the autism spectrum disorder, which is under the neurodiversity umbrella, is under these 3 levels. So let me explain a little bit better. There's 3 levels of this ASD, and it's based on severity related to how much support the individual needs to be able to function independently, okay? So level 1 is low support needs. This is probably most, if you're going to see neurodiversity, specifically ASD in an athlete, unless you're working for Paralympics and things like that, you'll probably see level 1. Most people that are not diagnosed are level 1. So athletes at this level, they're going to need some assistance to address challenges such as like social interaction, difficulties following directions, sometimes clothing, again, eating stuff. I'm going to get into all of that. But level 2, substantial support needs. So they're really going to be challenged and with verbal communication, really sometimes they're very limited interests, very specific, very focused, hard to get them out of just their sport, repetitive behaviors. And then level 3, this individual needs very substantial support, and they usually can't live alone. They need additional help to communicate, to interact with anybody. A lot of other mental health conditions going on in these in this level. Next one, please. So I don't know if anyone's ever heard of Dr. Daniel Amen, but I really enjoyed how he broke attention deficit disorder, and he uses ADD instead of ADHD. Again, just we're gonna not get too focused on that today, but he broke it down to 7 different types. And I felt like this was a really good opportunity to kind of bring this in because I find it so interesting and I use it in my clinic all the time, and it's so helpful because we really misdiagnose ADHD. BGSM and a few other podcasts, and there was the AMSSM ADHD position statement has definitely been like a lot of my work and centered around athletes with attention deficit disorder, and specifically women that maybe have been misdiagnosed or, you know, just kind of told that they didn't have that, it was just anxiety, things like that. So if anyone wants to get more into that, I can send some of that stuff over. But you know, all my insight from ADHD definitely started when I, you know, got more interested in Dr. Daniel Amen's work and how complex it actually is. It's not just so simple as like squirrel, oh, okay, you have ADHD. So I'm not gonna go too much into them. I kind of broke them down just if anyone wants to go back to the slide and understand a little bit more. They're all kind of treated a little bit different. So I'll point out some important parts, but classic ADD or AD is just your typical forgetfulness, losing things or unorganized, careless mistakes, you know, trouble listening, and really just difficulty with the executive function things. This one is more common in cis males, and all the other types have classic AD symptoms as I'm going through this, okay? So second one is inattentive ADD. They appear very unmotivated, and this is a big one. So if you see an athlete that just doesn't seem very interested, you know, always something to consider. You know, use your judgment if that warrants further testing or talking to somebody about it, but they often feel tired. It's like this lack of energy. They're just like, a little Eeyore-ish, you know, introverted. And introverted doesn't always mean keeping to yourself. Sometimes it's, I don't express my emotions until I process it. So there's little difference in the definition sometimes of introversion. They daydream a lot, big symptom in this type. And then there's over-focused ADD. Again, has all the classic ADD symptoms, but it also hyper-focus. I see this one a lot in my cis female athletes, and it gets missed because they'll be so good in school because they're so focused and they have to be the A student and the best here and there, and oh goodness. So it's exhausting, and it just almost looks as OCD because they're so hyper-focused on something. And the very negative thought pattern. If I don't do this, I'm not good enough. And they just beat themselves up kind of situation. The fourth one is temporal lobe ADD. And again, all classic ADD symptoms, but a lot of mood instability, a lot of aggression, a lot of temper, outbursts. So a lot of my athletes that I see with temporal lobe ADD have suffered a pretty traumatic brain injuries. So I see that one a lot in there. It almost looks like a borderline or a bipolar disorder, things like that. And then the fifth one, limbic ADD, it's like depression features, but related more to ADD. And it's really interesting. If you give them a stimulant, which increases our dopamine neurotransmitter, they do so well. And all of a sudden they're not depressed anymore. And you just have to teach them how to manage it in that way. So the sixth one, Ring of Fire. This is also like a cyclic mood change. They're a little more impulsive, and it's very consistent symptoms to like bipolar. So these can get confusing, the temporal lobe and then the Ring of Fire. And then the seventh one, anxious ADD. This is just magnified by anxiety. Like I just can't sit still. It's the movements, the physical stress. You can see it in their body. So like social situations, just hate them, avoid them as much as possible. And we really want to calm and stimulate the brain when it's this seventh type anxious ADD. If you give individuals with an anxious ADD a stimulant, oh goodness, we just made their anxiety so much worse. So again, just kind of like a, you know, vague scope of these these 7 types that I just really am just appreciative of Dr. Daniel Amen for making these, and I use them. I kind of change the lingo sometimes, but people really resonate well with them. So next one, please. All right, let's talk a little bit more about the important concepts that I see often that I think will be useful to understand about neurodiversity. So they're listed there, and we'll go to the next slide and just kind of take one by one. I'm not sure if anyone's heard of interoception, specifically interoception dysfunction. And interoception is how do we perceive our body in space and time, right? So do I have to go to the bathroom right now? Or is it like a buildup? Am I hungry yesterday and I'm about to pass out? Or has it been like a slow buildup? Not really being able to understand hunger cues, feeling like thirsty, it takes them so long sometimes. You know, again, we talked about like bowel movements, things like that, feeling hot or cold, all of a sudden freezing. It's not like a slow buildup. There's no perception of the body change. So this is a really big deal when it comes to injury. You know, somebody not noticing that they're injured, are they able to just keep going? No pain, no gain? Or is it they don't have any pain until it's like really far along? And I see this so frequently. It's kind of heartbreaking sometimes because they just don't understand, or they don't like know how to be aware of their body in that way. There's also a term called disembodied, and if anyone's heard of that term, that's very frequently seen with a lot of trauma disorders, PTSD, things like that. Like I'm gonna step out of my body, dissociate. It almost can kind of look like that. Those two get a little confusing depending on what type of individual you're helping, right? Whether they have trauma plus neurodiversity. So it can get kind of complex there. So any sudden change in disposition, so they'll have a significant mood shift just because the sensory changed in the environment. So lights were really bright, equipment didn't fit right, or the tag, something like that of their clothes, and all of a sudden it's just 0 to not happy really fast. Next one, please. Alexithymia, such an interesting concept. So alexithymia is difficulty identifying, understanding, and expressing emotions. So if we can't identify how we're feeling, we definitely can't understand it, and we definitely can't show the world and others our emotions. And this can be so tough because somebody will come in and they're just like, I'm sad, I'm depressed, or I'm happy. But that's it. There's no other ability to kind of decipher what am I feeling. So this has been really just encouraging in my job day to day of teaching people like, okay, if you can't describe your emotions with words that, you know, neurotypicals might use, let's do colors or let's do shapes. And it's really beautiful to watch. They resonate with that so well. And think about though how difficult it could be to communicate to a coach or to our incredible athletic trainers, I'm in pain or I'm sad or I'm having a bad day, when they don't really even understand that that's happening to them. Next one. So how to recognize neurodiversity in athletes, but specifically unique eating and food preferences. So near and dear to my heart, I love taking care of individuals with eating disorders. It's a huge passion of mine. And originally when I went on my own and started my own clinic, it was only going to be eating disorders. And I saw very quickly how interconnected neurodiversity was with eating disorders. And that just paired together so well. And I saw how much I was helping both of those conditions in the same individuals. The way that I have seen eating disorders improve by helping them like understand their neurodiversity and have control over their life and their thoughts and their actions has been so incredible. So highly recommend it. You know, really just kind of looking at all of this and putting it together and helping all of our athletes. So when it comes to foods and taste and sensory, neurodiverse athlete doesn't necessarily like the typical athlete meal. Okay, which can be kind of rigid. It's usually brightly colored. It has all the your carbs and your protein and your fruit, and you know, it's just eaten in these food groups, right? So let's add something like exteroception. So this is like food aversions or craving patterns. There's something called ARFID, avoidant restrictive food intake disorder. So it's like anorexia nervosa without the desire to lose weight, but they'll get stuck on like, I can only eat things that are white, or I can only eat things that are a vegetable. And it sounds like, okay, of course that person's dieting. It's really not always that. I've had somebody who was so afraid of choking because they choked once when they were alone, that it ended to severe weight loss and this fear of constant anxiety. Also, somebody who was worried about bacteria and like food being bad. So literally just couldn't eat anything that wasn't in these special packages. And that anxiety cycle can take off really fast. So if you have somebody who doesn't like sensory or gets sensory overloaded, plus doesn't like certain colors or tastes or textures, it's kind of easy to develop aversions. So again, that's why you'll see a lot of neurodiversity sometimes with eating disorders. Interoception, which we've already talked about, but it's their inability sometimes to determine that they need nutrition or hydration, which again causes lots of challenges. Inflexibility, so consistent foods, as we already talked about, like only eating these same things. These are my safe foods. Can look so much like anorexia nervosa, which we learn about the restrictive type all the time. But again, it's not that clear and simple. And then they don't always like specific meal times, right? So there's a lot of patterns or structure that neurodiversity can lead to. Like I can only eat at this time, or I don't like eating in front of people or with people, or if I'm in a moving like vehicle. And then deficiency in the executive function. So not being able to meal plan. And I say to my patients a lot, I use the term paralysis by analysis. So if you tell sometimes a patient with neurodiversity or an athlete with neurodiversity, okay, we're gonna go to the grocery store and you're gonna plan your meals for the next week, it's like total freeze. Like, I don't know what to do. I'm just gonna stay right here and not go to the grocery store or eat at all, because that's so overwhelming. Next slide. So stimming. Oh, stimming is so interesting. It refers to repetitive movements or behaviors used to focus or calm the senses. Stimming is not necessarily a bad thing. It can be. So for example, if somebody has a movement stim, that's like lip or fingernail biting, fidgeting, rolling fingers like that, you could get like a eczema or like wounds, stuff like that, or they'll stand on their toes or something. So now they have an injury going on down there. They also like pick at objects, pick at their skin. And then there's tactile, so drawing or like ringing patterns with their hands or swaying. And then there's also verbal auditory stim, so humming after eating, repeating phrases, mantras over and over and over again, which again could look almost like an obsessive compulsive disorder, but which is again under neurodiversity. But it's really important to understand, is this a stim or is this a compulsive behavior that I'm doing? So again, never simple. It's always a little complex. And then there's the visual stims. These are like staring at an object, turning lights on and off, wearing or removing sunglasses, excessive blinking, just different things that will calm the brain. So if they feel overwhelmed by sensory or an environment shift or social interaction, sometimes they'll go to stimming. We all stim, everybody does it, but it seems to be more common in this population. Next slide. So I made this little acronym for the reasons for stimming. Soothe, so to stimulate, they want to engage the senses when feeling bored. So we've all done that. Like you're sitting there bored and you start like munching on your chips, or you start squeezing your stress ball or whatever. So overwhelmed, coping with too much sensory overload from people, from animals, from, whatever it is, the stress of the game. Organizing, so sometimes to regulate emotions in the brain that they can't understand because of alexithymia. That's how they'll manage their anxiety, is they'll self-soothe with the stimming. Translating, so they can identify their feelings or understand them or express them. So maybe they'll circle a lot, or they'll sway, use their hands, they'll bite something if they're like worried. And again, that's another way that we see stimming. And then to heal, to relieve that physical discomfort, to manage pain, and then also expression. So to provide an outlet for feelings and just sometimes just being an individual. They don't feel like they can be themselves, or they know that they're different. So stimming will calm those kind of negative thoughts that they have about themselves. Next one, please. Okay, so some easily overlooked traits of the neurodiverse athlete. We do know that there's an altered alpha modulation that's pretty long, like the long-term memory in these athletes. And that can lead to a lot of emotional dysregulation. So, not like having a breakdown from something that might not seem important to somebody else, but it's more of that buildup that they can't express or they can't understand, or maybe they've been stimming to kind of avoid that's been bothering them, and then all of a sudden it's just like a blow up and it's an episode, and it just can look like a lot of they're not able to hijack their nervous system big time. And then also they'll have like enhanced sensitivity, so they, something that doesn't bother somebody else, like the heat, might just really irk them in a way, and it seems like they're overreacting. And then sensory overloads, which we kind of already talked about, and difficulty recognizing and identifying nonverbal cues, which I'm going to get into in a little bit, but it actually might be my next slide, Michelle. So I'm going to have you switch the next one and the next one. Sorry. Okay. Yes. So challenges in communication. How to explain this? This is, I'm gonna do my best here, but neurotypical athletes, or the red side over there, they want to avoid disrespecting other people, right? The first thing is like, oh, I don't want to make my coach mad, or I don't want to disrespect my athletic trainer. So they're going to maintain this social hierarchy with relationships. They want to feel and look socially acceptable. And again, not every neurotypical athlete is going to be like this. I'm talking in a general sense here, okay? Now let's switch over to the other side, the yellow, the neurodiverse athletes. Direct, clear, get to the darn point. They want accurate information, very detail-oriented, very logical usually, short and sweet, and that's it. They're really not always worried about being socially acceptable, or so much so that they end up masking. Like they know that they want to just blurt out how they're feeling, or they think they're feeling, or just get to the point. That's what they want to say if somebody's having a conversation, but they're so afraid of like almost speaking what they want to speak and being so direct and clear, they have to like hold it back. And that's what we call masking, like trying to be more neurotypical. And this can just be so confusing. People can come off very not authentic and troublesome, like just trying to be difficult or rude. And it's really heartbreaking to see, because a lot of times neurodiverse individuals know that they do this and they can't stop, or they don't know how. And it's also a beautiful thing. I think sometimes maybe we all need to be a little more truthful, right? The truth will always set us free. So I've learned a lot from my wonderful clients that I get to see. So next slide. So here's some more challenges in identifying neurodiversity. And I'm sure anyone who's kind of heard of neurodiversity, autism, ADHD, you can hear that they're not empathetic. And empathy, in a definition, is holding or understanding somebody else's emotions, right? Not everyone can do that, and not everybody wants to do that, but that is what empathy is. And there's 3 different types of empathy, and it's completely false statement that people that are neurodivergent or autistic, that they don't have empathy. They just display it differently sometimes. So there's 3 types of empathy. The first one is affective, feeling with people. It's the ability to sense and feel the emotions of another person because they're experiencing it. And then we have cognitive empathy. Do I understand the other person's perspective of the situation? And compassionate empathy, so feeling for people. You don't have to understand them, but that person's sad, and I know that they're sad, so I'm gonna go give them a hug, right? In general sense, neurodiverse individuals can struggle a lot with cognitive empathy. So I don't understand why you're sad about that. That wouldn't make me sad, so that's just silly, like done. And then we have that direct communication, and then maybe they feel something, they can't explain it because they're struggling with the alexithymia. As you can see, this could be very challenging. Next one, please. Okay, a few more. So we already talked about the neurocognitive concepts that can make a lot of so many difficulties in diagnosing neurodiversity. So that interoception, that the dysfunction of it, the alexithymia, eating stuff, like just all of that. And let's talk about a little bit about testing. Challenge number 2. Neuropsych testing is unbelievably expensive. I don't know if anybody's had experience with that, but I remember when I was working for the Division I and II university, oh goodness, it was thousands of dollars to get a neuropsychologist like to do these tests for our athletes. Just usually not actually have the tests that were helpful to identify this stuff. I have a little bit of a beef with the neuropsychology testing sometimes that we do, I'm going to be honest, just because it's so old school. Like it was screening tests from so long ago that really miss the hyperfocus ADHD, that misses the autistic and the person that's autistic that doesn't bang their head against the wall or isn't spinning, isn't obvious, that level 1 maybe, and that is functioning. And you know, you spend that kind of money on a test, then to not really get anywhere from it and maybe not get the help that we need, it could be really not validating and not empowering, and that it just can be more bad than good sometimes. But then at other times, it's fantastic and it's super helpful. So I think just having that conversation, maybe explain the limitations, understanding what you're ordering, what you're suggesting, and just because that test maybe says something doesn't mean that's necessarily what's going on. And just really just open mind about it. The third challenge is resources. Back to the testing, we don't have the money and the funding to do that in a lot of sports, regardless if we're talking Olympic or Division 2, 3, 1 college sports, high school, same thing. Even insurances don't usually cover a lot of the testing, and they certainly don't cover a lot of the treatment. There are some different treatments, which we'll talk about, but a lot of those are out of pocket. And then you know, this impact just on the world and being different and all that stuff that's going on right now, right? We want to unite. Yoga means like unite, like egg yolk, right? I'm such a yogi, but we want to connect, but sometimes I feel like we're all just pulling apart so much because we want to be different and we don't want a diagnosis, or we do just so we can stand apart. So just being aware of that. I've had a lot of athletes get stuck on the diagnosis or be ashamed of the diagnosis. So that might be another limitation to diagnosing. And then the support, it's a huge challenge. I don't know a lot of sports doctors that are familiar with neurodiversity or eating disorders or those things. So it's hard, you know, and it's hard to find a team sometimes and to educate, and everyone has different ways and every athlete needs something different. So I think we're all just doing the best that we can. Next slide. Prevalence of athletes with neurodiversity. I don't know what to tell you. I have no idea. We don't have it. I've really been trying to get the word out there and just making kind of like a mission of mine in my career to be like, we need to start testing this and we need to start thinking outside the box. Again, if we have a neuropsych test that is not really super accurate, unless it's the very obvious neurodiverse, it doesn't help us when we're doing research to to understand the prevalence of athletes. Again, there's the shame component. I don't want to be labeled as that versus, I do have that. I'm going to make myself look like I have that. And then neurodiversity is kind of a new term, right? So this is pretty new. So again, we're a little confused right now on the prevalence, but to be continued. Hopefully we start to make a little headway in that area. And then we'll talk a little bit about physical health. Specifically to the neurodivergent athlete or individual, I see these often. I just wanted to bring it to everyone's attention. I just see this constantly throughout my work day, but chronic pain, pelvic pain specifically, which is interesting, a lot of premenstrual dysphoric disorder, things like that when it comes to the menstruation. I just gave a talk for the Pelvic Pain Society in Australia, and it was just very interesting to see how much pelvic pain is associated with the neurodiversity and a few other conditions. A lot of gastro complaints, migraines, fatigue, again, stuff that we all can complain about. It doesn't matter if you're neurodiverse or neurotypical, but again, these are just the ones that I see quite frequently. If somebody's struggling with interoception and they don't know their body and space very well, they'll faint more often. A lot of POTS syndrome, sleeping difficulties, and just really like tachycardia, heart palpitations. Again, see it in other athletes outside of this, but just something to be aware of. Next slide. So I made this little chart just to show you what I'm seeing a lot connected. And I kind of just do that with, hey, this is what I'm seeing clinically. I don't have a ton of research to back this up. There's individual studies, which I'm happy to share, but the more I just continue to practice medicine in this very narrow field, I'm like, wow, okay, this person's coming to me for hypermobility issues, like an Ehlers-Danlos, and then I find out that they had an eating disorder before, and that they also, you know, are ADHD, and like it's just been really enlightening to see how connected. Past few months, I've had 5 patients with endometriosis under the age of like 25 that was missed by so many gynecologists. There's something with mast cells, eating disorders, and then this dysautonomia, which is POTS, postural orthostatic tachycardia syndrome, and disordered eating. And it's just, it's called a pentad syndrome. Again, I can send any file or information, like article that you want, but we're starting to connect a lot of these things. So just something to be aware of, you know, kind of put in the back of your mind if you see it, you know, and they don't have to have all of these. It's just more common to have them together sometimes. Next, please. Okay, so pairing awareness. Oh, this is a tough one. And nociception is, I'm not sure if everyone remembers this back in the day when we were all first learning about pain and the biology and stuff of it, or physiology, but this is how it signals in the body. So if we have a cut, how it travels through the body to then start the process. Pain perception, as you can see from the chart, is all the way over here. So we're not even there yet, right? So it goes through our body all in kind of a different way, but kind of similar down these pathways, right? But we get emotional information and sensory information and cognitive information, and then we perceive pain. So these whole like 1 through 10 scales of pain drive me nuts because I just see such a different type of population all the time that means nothing to any of them. And truthfully, like we all experience pain in a different way, because if somebody's very sensitive sensory wise or not, that's going to change their perception. If they cannot handle pain, they're just shutting down cognitively, absolutely not. I can't be logical about this and say there's medicine or there's help. Their pain perception is going to be worse. And same with emotional. You know, do they have an emotional grasp over how to tolerate their body? And you know, it could just be a very unclear picture when we're talking about pain perception. So just be aware of that. In the next slide. So a little bit more on this pain perception, you know, they have unique pain perceptions. I mean, makes sense after hearing all those differences there. And then we add in the communication barriers, right? So, you know, am I too direct? Am I not direct enough? Am I masking? Things like that can make it hard for them to express that they're in pain, if they even notice that they are, right? And then we have this emotional and psychological pain. I often see that an athlete might be pretty shameful because they feel like they're always in pain compared to their teammate. So they're not going to share their needs, or, you know, that something's bothering them or they need help, or they should be better already from the injury. Again, these are things that we see in neurotypical athletes as well, but it's very interesting to watch with the neurodiverse athlete how prevalent this can be. And then the cognitive differences in the pain processing. You know, do they believe that they'll ever get out of pain? Or have they made this structure that the only way to get out of pain is if they do this, this, and this? It's exhausting. So a lot of things we've already talked about is very limiting to them being able to talk to the clinicians like us about what they need, because they don't even know what's going on sometimes. They don't even know how to express it, and then let alone ask for help. Or ask too much for help, maybe. It's never too much, but it can be. We've all been there. Pain scale that was developed for neurodiversity, which is so neat. It's color-coded. It gives it in a different, so numbers as well, but color-coded, but then it explains it. So it explains it in these little sentences, but it also explains it in one like word. So mild, this is very mild. It's noticeable, but I'm not thinking about it all the time, right? And then we should all use something like this. I think it makes so much more sense, and can be so helpful. And then everyone can kind of be on the same page, and it can be what it is specifically to them rather than as this like collective. Next slide. I want to talk a little bit about the gender differences in the neurodiverse individual. And I take care of a lot of transgender athletes and individuals just in general. And, you know, there does seem to be a big community of transgender with neurodiversity. I don't even want to get too much into all of that right now, but something to be aware of and just, you know, supportive. And the biological factors that I definitely see with a neurodiverse individual when it comes to gender, and we're talking about cisgender here, so anatomical differences, obviously pelvic pain, you know, menstruation, hormonal influences very much affect pain perception, communication, all of those things. And then impact of chronic conditions. So we definitely see a lot more, obviously endometriosis, of course, in the cis female, but the dysautonomia, that POTS, things like that. And then sociocultural factors, so stigma and culture. You know, there's a lot of stoicism, depending on which gender we're talking about, reporting behaviors, help-seeking behavior. You know, the studies that we do have on this, you know, are definitely like cis female are going to be more likely to report. But I feel like that was kind of just in general, not necessarily specific to the neurodiverse athlete. And then psychological factors, again, emotional responses. You know, I think it's fair to say that sometimes cis females are allowed to be more emotional than males, according to society. Unfortunate, but true. And their coping mechanisms can be different. Maybe a female's hyper-focusing on their ADHD, or their stimming looks this way, putting their lipstick on all the time. I had one of those once, and that was a stim. And then psychosocial factors, so impact of relationships, support systems, you know, definitely contributes to all of this. Next slide. And a little bit about emotional health, my favorite stuff to talk about. Okay, so I think it's just, again, important to bring up the pain thing and life stuff and how we look at the world, because that's how we're gonna perform and in our athletic ability, how we're going to interact with other people, our teammates, our staff, everything. So if somebody has a life event, just like pain, we have a physical response, an emotional response, and a cognitive response. And then we respond to the world based on that. So Gabor Mate is such an incredible doctor, and his work is just fantastic. And he talks a lot about trauma, and trauma isn't something that happens to us, it's how we hold it in our body. So what I see as trauma therapist is somebody will go through the same event as somebody else, but maybe it won't impact them the same way. So with a neurodiverse individual or athlete, they'll have a very significant stressful life event, and what everybody would think is the worst part of it isn't. And then they get missed by their therapist or their doctor. Well, it couldn't have been that bad because that didn't bother it, because they're fixated on the person in the yellow shirt that was standing in the corner when this horrible thing happened to them. So it's just really intriguing to kind of see the difference there. And because of that, they're going to have different emotions, or they're going to have a different physical sensation with it. And then they're going to develop this cognitive belief, like, though I can't trust anybody, or I can't trust myself, or I'm bad, or I did something wrong, or I'm never going to be good enough, right? And then they're going to go to the world, people, and have a perception of what that is. You know, I can't trust everybody. I can't, you know, I'm never gonna be good enough. And then they're gonna isolate, or they're gonna become mean, things like that. So we have perception expression there. Hopefully that made sense and paired with pain perception. Go ahead, next slide. Here's a little bit more about trauma. Trauma is emotional distress, whether it's conscious or unconscious. Because we don't say that car accident bothered me does not mean we're not holding it somewhere in our body. So sometimes I like to call bluff. I'm like, sure, it's not. Let's give me an hour with you and then we'll talk about it, right? And it's okay that we do that. We're human. We don't want to walk around being afraid of everything and stuck on things that have happened to us. But when we let things build up and we start to build beliefs, that's when it becomes really, really dangerous. So we ask somebody out and they say no when we're in high school, and then we keep asking people out, and then we become more and more shy because everyone keeps saying no. Like, I mean, that does really impact us, you know? So some simple example, but if you think about that on a bigger scale, it can be totally damaging. And it really manifests then physically and as chronic pain conditions, as injuries, lack of athletic performance. And the neurodivergent individual athlete, they have a real increased vulnerability to trauma because they're so sensory sensitive. They struggle with communication, and they don't feel often that they fit in with society, so they're masking. They don't even know who they are as a self, right? They're struggling to figure out, who am I? How do I fit in? Am I allowed to say this? Am I not? So it could be a little eggshelly, I call it. Next slide. So a little bit more about trauma. When we put it into our body, again, subconscious, it can come out in somatization. And we hear about this often. It used to break my heart when I was teaching a lot of med students and residents and fellows. We couldn't figure something out. Oh, the patient's just somaticizing, like brushing it off. And I feel like that's like one of my favorite things ever to talk about as a doctor. It's like, well, we just don't have the tools maybe to identify it, or maybe they're not able to communicate it. It doesn't mean that it's not happening to them. And it doesn't mean that it's all in their head. Right? So you'll see often when somebody's going through something emotionally that they can't express, particularly neurodivergent individuals, it's really just gets stuck in their body, like from muscle tension, which then is going to lead to an injury. They're more likely. Nervous system response, they don't know how to get it up and down and regulate it. And regulating our nervous system isn't about being calm all the time. Just like when we meditate, it's not about having nothing in our brain. It's about allowing the thoughts and just understanding them, or thinking about them, or acknowledging them. Same thing with the nervous system. We're all going to have challenges in life, right? Things are going to hurt. We're going to not be great at stuff. We're going to feel like crud, whatever it is. And we're going to be really happy, right? But it's just acknowledging what's coming into our nervous system, how to bring it down if we need to, and how to bring it up when we need to. And then maladaptive coping mechanisms. So if they're stimming, instead of maybe thinking about their feelings or their thoughts or what happened, it can get really missed. And then there's definitely a brain-gut connection. I feel like I'm talking about this all the time. It's like brain-gut connection and everything, but I really think that it's way bigger of a deal than I definitely thought when I was a med student or a resident. I was like, oh yeah, sure, there's stuff in our gut that's like helping our brain, but no, there is. Absolutely. We have a lot of serotonin receptors, so that's our happy neurotransmitter, and those can get really damaged, we're finding out, and really affect how we perceive the world, how we like go through trauma and stress, and how we heal from injury, everything like that. And there has been a lot of research about that brain-gut connection when it comes to autism and ADHD, and there's similarities between those two, and then also eating disorders. Next slide. So how does this all affect athletic performance? I feel like I almost don't even need to go over this, just because it's kind of obvious. I mean, if you can't understand your body in space, you can't talk about what you need, you feel like you don't fit in. It just sounds like a lot, but it obviously is going to impact the physical functioning and the psychological effects of how somebody's going to feel that they do at their sport. And then an altered response to training, of course, and then an impact on recovery. If they're struggling with an injury and they feel like they should be over it already, or they don't feel any pain to know when to slow down so it doesn't happen again, it just can be a recipe for disaster. We're almost done. So a little bit about the care of, how I hope this starts to go now that we become a little bit more aware of neurodiversity and maybe get some more research out there. These are just some things that I've found really helpful for my athletes that I take care of that have neurodiversity. Go ahead. So in the article that I wrote for the BJSM, I created this like personalized neurodiversity athlete program, and I could probably dive into this forever and like add more things to it, even from when I wrote this earlier. But it's definitely something I hope like continues to get worked on, or we can like advance or do something with to just kind of educate about this topic. But reducing distraction and mood alterations. We don't want to like ostracize people and say, oh, you have this disability or you have this diagnosis or this is how your brain is, and like make everyone feel so different or them expect all these things. We got to find a middle ground there. But it's just things to be aware of. Maybe you can help an athlete by just giving them a fidget toy or giving them nutrition reminders. Maybe they don't think like everybody else on the team does, So just being aware of it, adjusting environments or teaching them how to take control over their own environment in a healthy way. So, hey, if you know the lights bother you, it's okay to wear sunglasses, like, inside, whatever you need to do, but just understanding and kind of being a little creative like that. Clothing's a big thing. It's okay to take out the tag. Sometimes they don't know that they are allowed to do that, but that's something that really sensory like drives them crazy. Also, body doubling or buddy support is one of my favorites for ADHD. They'll struggle with motivation to get a task done, or they'll procrastinate, things like that. So body doubling or buddy system, go study together, go pick out your equipment together. It could be really helpful, that simple little change. And then establishing a structured and consistent routine with exercise and sessions and times. So if somebody is habitually late or overwhelmed, that analysis by paralysis thing, having structured times, super helpful. I'm always late in my clinic. It's not always me, but until somebody can get a hold of their neurodiversity, it takes a little bit for them to show up on time. So I've learned a lot of different ways of how to set timers, reminders, and things like that. And then for communication, again, I think I can learn stuff every day from direct, explicit language, using clarity. What is it that I'm trying to get across? What do I want that person to hear? Asking if they did understand it. The world would just be a better place if we all did that. So just being aware that sometimes that direct language might not be rude, and it just might be the way they communicate, or they're afraid to be direct because they've been told that they're harsh or something. And then providing that regular feedback and focusing on promoting them rather than saying they're doing something wrong. It's not about them having to be neurotypical or fit in per se, but understanding why they can't or don't want to or don't know how to, and kind of finding that middle ground. It's gonna be different for every situation and every athlete. And then psychoeducational interventions for everybody, mostly us, right? I think we have the biggest just the biggest power here to make change and to understand, and then we'll see more people come forward or have more ways to develop how to like make a specific program, or just devise certain ways that we can help these individuals. Next slide. There's still more components to this personalized neurodiversity athlete program, and assessing for dysfunction. So identifying any sensory processing difficulties. So you get so close with the athletes, and I just love athletic trainers so much for so many reasons, but nobody's closer usually to the athletes. It's just such a cool relationship to watch. So knowing that, okay, this athlete doesn't really like to talk about pain because they don't understand. It's just good. It's a good way to have this relationship with them, and maybe you just ask a little bit more, or they struggle with numbers, right? Or they're dyslexic. Just those things can be really important and not damaging to know and help and like guide athletes with. Also involving specialized instructions, like occupational therapy can be really helpful. Certain psychologists, eating disorder specialists, really like somebody who is neurodiverse affirming. So, this isn't, and this is my belief, some people are like, this is this is disability, and like they're going to go that direction, and that's fine. I'm all about empowering, affirming, hey, this is the way your brain works. It's different. How do we like get you to live your best darn life ever, right? And then trauma stress experts, I think, is really critical for neurodiverse individuals, just because of how it presents very, very altered. And then enhanced structure and organizations. Okay, so this is like timetables, goal setting, assistive technologies like calendars. I'm all about the calendars, one calendar, not a bunch of calendars. Don't get carried away drawing the calendar with all the pretty colors and stuff, just like focus. I feel like maybe we all should do that sometimes. But self check-in strategies. Did you stim a lot today? okay, maybe there's feelings that we need to address, that kind of thing. Just teaching them those things, or just being aware that this is stuff that is involving that neurodiverse athlete. And then providing visual supports, again, diagrams, written instructions, things like that. Next slide, please. So there's different types of therapies that I found really helpful. And I know we're about to go over time, and I'm so sorry. I'll talk fast. Cognitive behavioral therapy, I think it's helpful for this, but I don't think it's like the end all be all. But there's something called applied behavior analysis. Some people agree with it, some people don't. It's for specifically autism. Not my jam, to be honest. It's very much like fit in with neurotypical rather than like empower, embrace your differences kind of thing. But again, it has its place, has its purpose, depending on the age. DBT, this is more for like how to function in emotional relationships and control that kind of stuff. EMDR, a big part of my practice. It's eye movement, desensitization, reprocessing for trauma, as well as ART. There's something called ACT, physical therapy, occupational. Bring it all in, see what they need, make their individual plan. And then next slide, please. And then mindfulness is obviously, I love all this stuff when it comes to yoga and meditation and mindfulness, and it's a big, huge part of my life, but also what I promote in my clinic and what I teach, breath work, aromatherapy, whatever is going to get somebody to feel like they have control over their life and their happiness and their athletic performance and their academics. I'll go in any direction. So be creative. If you don't know it, just learn about it, or be open-minded to it. So, and the next slide. And here is just a pretty much breakdown of all the different stuff that we can do to help. If somebody's really struggling with malnutrition, because the eating component, really just assessing different vitamins, things like that, and like all the different supplements, stuff like, there's different supplements that can help certain things. I test a lot of neurotransmitters, like looking at dopamine, looking at serotonin, seeing what the actual levels are. I do pharmacogenetics. I find that stuff that could be helpful. Again, it's not really practical in athletic settings sometimes. So again, just things to be aware that are out there. Maybe they have resources outside of athletics, wherever we're practicing or how it's working. And then there's also prescription stuff, stimulants, things like that. Peptide therapy, pretty cool. I definitely think we're going to see medicine go a little more that direction. I could talk about that all day, so I'm going to keep going. And then medical cannabis. I'm writing the position statement right now for AMSSM on medical cannabis in athletes. We have like no research on it. I'm actually finding a lot of stuff about neurodiversity, and they'll go to certain types of cannabis to help. And more to come on that. Also a lot of it with concussions, and it's just some interesting stuff out there. And I think that's my last slide. Yes, and the most effective way to provide care is through an open mind and accepting approach. And I think athletic trainers are the closest that the athlete has, and it's just such a beautiful relationship. So if I can ever help in making that better, please don't hesitate to reach out. And thank you so much for having me today, and appreciate it. And these are just references. That's about it.
Right. We will give people a couple of minutes to pose questions into the question tab. I've got that open now, so. And then I think maybe while we're waiting on them, Dusty, this could be a good time, if you don't mind telling us about like what your practice is in person, it's virtual, like give us a little, yes, I think this would be a great time to do that.
We go so way back, as everyone wants to know. I just adore Dr. Henny so much. We, got to go through fellowship at the same time and all that fun stuff. So she's seen me go to private practice from a university setting, which is so scary. And she was such a beautiful mentor. So thank you, sweetheart. But it's evolved for sure. I think I started as just eating disorders. That's the only thing I was going to focus on for athletes. And then, as I said earlier, like the neurodiversity and the complex concussions, I saw how it was all connecting. And, you know, I hate using the term hippie or esoteric, but I'm like so like that, and I just love all that world. And there's a lot of athletes that are very holistic, and it's cool to be able to bring that to practice, to help them from a medical standpoint and to bring science into it. And so that's been a big part of it. I'm virtual, and also I have a clinic in Tampa and a little office space, but I've met athletes at random places if they're comfortable, like, you know, a coffee shop or something. So like it's pretty fun to just kind of be a little whimsical about it, you know. But do a lot of regular medical stuff too. I'm still taking care of you know, their regular primary care issues. And yeah, I bring yoga into the practice, do a ton of breath work, standing on my head sometimes throughout the day. It's a good time, but it's fun to teach those things. You know, it's different. It's very atypical. But a lot of stimming toys in my office. It's like the coolest playground, honestly. Stuffies, you know, like all of that. So it's fun. My dog comes with a tie on every day. People ask for him. I think he does more good for them than I do. And his name is like Mr. Pappy Van Winkle. So like, that's just ridiculous. But yep, he knows when to give kisses and hugs, and like, it's good. It's fun. It's fun.
Okay, there's a question coming from Muriel, and the question is, living in a rural area, we have limited access to specialized healthcare specialties. What can I document that would help in advocating for an athlete that might need neuropsychological testing?
What to document, like symptom-wise, or like what to ask for? I'm kind of not totally sure on the question. Or you help me
That's the question I have. And yes, if you wanted to maybe kind of tease that out a little bit, or we could wait, and I'm sure they'll post some clarifying.
So what I've done, I'll just give you an example, and maybe this will help that question, but is I'm not the biggest fan, as I said, about some of the neuropsychology testing, and people can't afford it. Like, you know, even in rural areas, they can't afford it. So I've kind of created my own. I've gotten a bunch of the validated tests, and I put them together, and then I'll have my patients do it, whether virtual or not. So, you know, I see a lot of people rural, and hopefully other clinicians can start to maybe do stuff like that too, you know, so we can give that type of care or assessment. And you know, it maybe isn't a neuropsych testing in the standard way, but honestly, that it's pretty amazing. You can really get so much information and at least teach them about themselves, you know, in that way. And it could be so helpful because it's about them, not always just having a diagnosis. So
the next question comes from Barbara. How can we tell the difference between the different ADDs?
Yeah, so good luck. Just kidding. Like it's tough. I mean, and you know, it's just what works for them, what doesn't. You know, for example, the anxiety one, if they're anxious, it's usually very physical. So like I kind of watch for that. I've given stimulants to somebody who definitely ended up being an anxious, more ADD type, and it was fine, but it definitely didn't make them feel better, right? Whereas the limbic, that did help. So sometimes it's trial and error of medications. It's really asking those questions. Like, you know, if somebody's hyper focusing on something, they often are like, oh no, I don't have ADD, because they always think it's squirrel, and it's not that. So just really asking them, where are you struggling in this executive functioning? Like, teach me more, show me more, explain more, give me various examples, rather than just like the validated like tests that we have, I think, out for the book.
Yes. And so in the follow-up there from Barbara is, other than the symptoms, does regular testing figure that out? I'm afraid everyone gets the same medication.
Very true. And they also get the same testing, right? These like 2 or 3 screening tests, which again, it's what we have, or the neuropsych testing, which will identify anxiety sometimes and not anxious type ADHD. So Dr. Amen does something called a QEEG. He does different like functional MRIs, things like that. So I love the QEEG, pretty cool science. You're looking at the brain in how it's responding. Is it over acting or underacting in certain areas. So that's pretty like in-depth, crazy cool science stuff, and definitely not like mainstream, but a lot of people are looking at different parts of the brain. So if the temporal is like super active, the temporal lobe, that's gonna be more the temporal ADD type. Not everyone can afford that kind of stuff. Not everyone needs it. But just to answer that question, there are different ways to do that. And honestly, just looking at the athlete and does this make you better? Does it not? You know, sometimes it's not always about the stimulant. They have more stimulants coming out. There's a new one now that you take at bedtime and it releases like throughout the day, and it doesn't really like inhibit appetite. Again, not all of them do, but that's a new one. So I think we're starting to wake up and create different stuff that hopefully will help to tease out the different types. And again, not everyone follows those types. That's just something I like that he created. So, you know, you can just stick with ADHD, inattentive versus hyperactive if you want.
Okay, well, thank you so much for joining us today. Thank you so much for presenting this information. Thank you to all of our attendees. Certainly, like I said, we had a little bit of some technology things happening through our website. So please give us a little patience. We'll get that situated by the end of the week. And then please provide us with feedback. I know Dr. Narducci is looking for some feedback, considering some of this information may get presented again at some big future things happening. But yes, so thank you to everyone for attending today.
Thank you. Thank you.
All right, have a good day, everyone.